Good afternoon, everybody. Welcome to our roundtable. We are so excited about this edition. And of course, we are celebrating Black History Month. And I can't think of two people that help to make up history. History is history, whether it's Black or white or green, but we are here to celebrate it. And with us today is Dr. Velma Scantlebury, who we all know, and we're going to let her tell you about herself. But she is the first Black American to be a transplant surgeon, female, in the United States. And we have Dr. Clive Callender, and he is the founder of many things at Howard University. And I welcome both of them, Dr. Scantlebury and Dr. Callender. Welcome, welcome,
Thank,
welcome.
thank you very
Thank,
much. Nice to be
Okay.
with you.
Yes,
thank you. So excited to be
absolutely.
here.
Absolutely. Now, Dr. Scantlebury, I'm going to introduce you first,
hmm
because I'm going to females first, and also the fact that there's a lot to say about you. And you're very special to me because you did my transplant 15 years ago, and is still, I don't know what you did, but you did the right thing, and I'm so grateful to you. And of course, we're very proud to have you as our medical consultant. You've been an asset. Every time we ask you to do something, you do it, and we know that you're busy, but you've always managed to fit us in. So just tell us a little bit how you even got into being a transplant surgeon. Because I'm sure when you first did it, it was male dominated.
Yes,
Yeah.
absolutely. It was quite interesting. I was actually, during my surgical residency at Harlem Hospital, I my mentor, and at that time was a pediatric surgeon, Dr. Barlow, and I wanted to be just like her. But to become a pediatric surgeon, I had to do research. And I was able to do some research with Dr. Mark Hardy, who was at Columbia University at the time. And so I got inspired to do research in transplantation so I can become better qualified to be a pediatric surgeon. And so I was then invited out to University of Pittsburgh, the transplant mecca, where I was doing 2 years of transplant surgery, what I thought was a fellowship, research fellowship to become better qualified to be a pediatric surgeon. And so that led me to transplantation, coupling that with pediatric surgery because that's where I was able to do most of my fellowship at Children's Hospital of Pittsburgh and do both adults and children. So that was my journey into transplantation, and that was many moons ago. I There were two women before me in terms of Caucasian women in transplantation, and out of Minnesota fellowship program. Uh, but I soon learned after I was in my second year that there were no other Black female transplant surgeons, just Dr. Callender and probably two others as males at that time. So it was not only was I the first female transplant surgeon at the time at University of Pittsburgh, I was the only female surgeon in period. So
Mhm,
that was quite an awakening to be in surgery and have no others that looked like me.
mhm. Dr. Calendar, it's your
Yeah.
turn. I would first like to say, one of our staffers sent me an email one day and said, I did some reading and I found out about a Dr. Clive Calendar, and we should think about having them there somewhere. Well, I thought about it and I talked to our CEO, and he said, by all means. So we've been thinking about having you for a long time, and I cannot think of a better month than Black History Month. And just tell us a little bit about yourself because you have a lot of accomplishments.
Well, where do I begin? I actually, at the age of 7, I decided I wanted to become a medical missionary. And so from that point on, I had decided to become a Christian at the age of 7 and felt that it was my calling to become a medical missionary to Africa. And so for the rest of my life, I did everything that I thought was appropriate to become a medical missionary. Along the way, at the age of 15, I contracted pulmonary tuberculosis, and I had to be in the hospital for 18 months, and had to have half of my right lung removed in order to survive. Uh, but anyway, after that, I finished high school, went to college, Hunter College in New York, and uh, made it in spite of my low grades. Uh, for example, when I was a freshman in Hunter College, my grade point average was something like 1.8 the first year, and then
Mhm.
2.5 the second year. So nobody really thought that, seriously that I would make it into medicine, but except me, of course, because I felt that's what I was led to do. And then eventually, uh, I improved my horrible scores, and I was able to get all the way up to a grade point average of 2.5 out of 4, and was miraculously accepted into Meharry Medical School. And in spite of the fact I didn't have any funds or ways to do it, my church actually put together their funds and sponsored me so I could actually go to medical school. And finished medical school and decided that I wanted to be a surgical missionary because when you do have successful surgery, the results are so quick that it's much. It was such a fast reward that I decided I wanted to be a surgical missionary. So when the opportunity came, myself and my wife went to Port Harcourt, Nigeria, to have my life's dream come true. After I spent 9 months in Port Harcourt, Nigeria, and helped rebuild the Port Harcourt General Hospital, which was devastated as a consequence of the Biafran crisis. Uh, After 9 months, I returned back to DC, but I had lost 50 pounds. And I wondered whether it was for me to continue to be a medical missionary. And so I looked at the opportunities, and an opportunity presented itself for me to go to the University of Minnesota if after my second trip to Africa, things didn't work out. And so I went back to Africa for another 3 months just to see what would happen. I contracted malaria, lost 25 pounds, and decided that I would go into transplant surgery because that was a new field. Didn't know anything about it, but Dr. William Mattori at Howard had introduced us to transplants in the animals, and so I knew nothing about it. So I took the opportunity to go to the University of Minnesota and learn about transplants. And after I did my training in transplant, I went back to Howard to start a transplant program. And in 1987, I decided we wanted to do livers. So that's when I met Dr. Scantlebury, the University of Pittsburgh. Uh,
Mhm.
she was the Lone Ranger, as she said. And it was interesting to see her there then to meet her. I'd actually when I had my TB, I was at Harlem Hospital, so I knew
Mhm.
much about good old Harlem Hospital, and so with that in mind, I went back and did liver and as well as kidney transplanted at Howard University Hospital for some 30 years, and so. To make a long story short, I've been blessed to be the third actual African American transplant surgeon. Sam Kuntz and I forgot the other guy's name. Were also they were my predecessors, so I was the third African American transplant surgeon in the United States. So I've been blessed to be able to be doing this for close to 60 years. And so
Mm. So you're
uh,
what? You're just 70?
89.
I know I wanted you to say it because I think that's history in itself. And
Yeah.
I didn't mention that because a lot of people don't mention their age, but it's
Oh, I'm
something that
proud of
you
my 89 years.
good. I am
Yeah.
too. And you're still working, right?
Yeah. 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 Still
Yeah, I
working.
wish we could hear of all your experiences, but we're limited to 4:30, to half an hour. But I think the important part of what you said is the fact that you saw the need and you started you started a division in Howard University to do surgery. And I'm sure a lot of your patients were probably people of color, which sometimes we don't get the opportunity to even see a nephrologist or a transplant surgeon. And not only did you do that, but you were a part of that whole experience. And tell me how you know that you catered to some. And the reason why I'm saying this because we put out e-news every month. And one of the articles that I wrote this month was about how people of color don't get the same opportunities and wait longer than people that are not of color. And that's a known fact. Whatever you read about that, they'll talk about one of the disparities of African Americans not getting the same treatment as people who are not of color. How did your business at Howard University, how did that, I'm trying to make sure say this correctly, but how did your university counsel to people of color and cater
Well,
to them?
well, that's been our history. And so we have always been, uh, regardless, we take care of people regardless of color, but we were
Hmm.
right in the heart of DC, which was predominantly black. And so,
Right.
but the thing that I noticed was that most of the patients that I transplanted were black, but most of the donors were white. And so
Mm.
I recognized early on that we had to do something in our community to become
Hmm.
more donors. And so, with that in mind, we started MOTEP, the National Minority Organ Tissue Transplant and Education Program,
Hmm. Hmm.
which catered to people of color.
Hmm.
Uh, and as a consequence, over time, the number of African Americans who donated uh, uh, actually quadrupled, and the number of people who were not minorities doubled as well. So that we were very fortunate in the sense that we started early on and started programs that educated and empowered the minority community to become part of the donor and recipient population. And so
Hmm.
I've
Hmm.
been blessed to be able to see that MOTAP has made a tremendous difference in terms of
Yes,
the
yes,
donor rates.
they have. Dr. Scantlebury, I have to get you in this conversation. I know that you're a big advocate and aware of the fact that people of color are treated differently than people who are not of color. Dr. Scantlebury, how have you dealt with that? Or I know you're very familiar with it. How have you dealt with that?
I think one of the issues when it comes down to uh, melanated patients and our disease process is really understanding, really having a physician that recognize that this is something that needs to be addressed. So many times physicians dismiss patients of color with their disease process of, well, it's nothing to worry about, or the lack of appropriate information. And that's so many times I see patients who didn't know about transplantation, even though they were on dialysis, or
Mhm.
should have been given the information appropriately, or they were then viewed as not suitable candidates for transplantation without even having that discussion with the patient. Someone made that subjective decision not to refer them. And in theory, by Medicare rules, patients should be given that information and choose to accept the referral or not. But oftentimes that you'll talk to nurses in dialysis units and they'll say, okay, so-and-so is not a suitable candidate. Well, how do you know?
Mm-hmm.
And so there's those subjective decisions, and that's where I think is important for community education, for us to educate our
Mm-hmm.
constituents either through seminars or whether we're doing it in the churches, so that there's that awareness of when to intervene and when is the appropriate time, understanding that there are different options for
Mm-hmm.
end-stage renal disease. And
Mm-hmm.
it's not just hemodialysis, understanding that that information can be gathered and can be done early. Unfortunately, oftentimes African Americans are diagnosed late, so the first time they hear about their kidney disease is when they're in stage 4, going to 5, or in
Mm-hmm.
the emergency room going, "I'm sorry, but we're going to have to start you on dialysis in the next day or two." And in those
Mm-hmm.
situations, then there's not an opportunity at that point. You just know they hear dialysis, and the feeling is that this is where we need to, this is all that I know about, and this is, and from there on, so the education gets missed. And I think
Mm-hmm.
that's real. Oftentimes I have to push patients to say, you need to talk to your nephrologist about, while you're putting in a fistula, what did you hear? Did you get information about peritoneal dialysis? Did it give you any other information
Mm-hmm.
other than the fact that you need a fistula? That's why knowing your options is key. And if
Mm-hmm.
nothing else that we can do with DPC, and also educate those already who are there, educate others in your family, is that know what your options are. Speak up for
Mm-hmm.
yourself. If you can't speak up for yourself, make sure that you have an advocate who can help speak up for you and ask those
Mm-hmm.
questions of your caretaker, because we get dismissed as people of color. And whether, where we know Dr. Callen says it's institutional racism, where a value is placed on you as a person, where you are not deemed suitable or worthy of this process because they don't see you as surviving. And so I think that's very important to
Right.
understand. Yeah, not everybody can be a transplant candidate, but when it comes to heart disease and getting the appropriate tests or getting referred appropriately, then we tend to bear the brunt of the mortality because we're not in line to receive the appropriate testing.
Right. I'm going to ask you one more question and then I'll move to Dr. Calendar again. But what are some of the explanations that are made when a person is dismissed? Do they get back to them and let them know it's not your time, or when a person is overlooked? Because that's one of the biggest disparities.
When you say when they're overlooked, you mean on the list or just not?
Oh, overlooked in the whole process.
But
You
see,
know,
often you see, oftentimes patients will rationalize the fact, well, I guess it didn't get back to me. I guess everything is okay,
okay.
or I guess maybe I'm not suitable. So they make assumptions as opposed to addressing the issue.
Okay.
And
Okay.
oftentimes as patients, we are intimidated by our doctors, so we don't want to ask them questions because you figure their decision is, well, maybe they're right. Well, maybe they're not
Mm-hmm.
right.
Mm-hmm.
Maybe you should be given your options. So I think that is important, to not accept that one decision if you know in your mind that there's, you deserve better, or you, and
Mm-hmm.
understand that you can always get another opinion when someone dismisses you. If
Mm-hmm.
you
That's
feel
right.
that your doctor is not appropriately looking out for your best interests, and that you feel that they're not addressing your issues, then maybe you need to find another doctor, because
Hey,
they get paid for your insurance is paying for them to be on the golf course. So you have to be able to have that relationship where you can be able to have that conversation with your physician or
when
your
I hear a
healthcare
doctor,
provider.
when I hear a doctor say, get another doctor, I gotta go with that. Dr. Calendar, um, what has been your biggest challenge being in renal care and moving on from a transplant surgeon to just a nephrologist, and not just but a nephrologist now? How are you dealing with that, Dr.
Well,
Cal?
I've always and always will be a transplant surgeon, but my effort has been to go into the community to educate and empower them. Because as Dr. Scantlebury has indicated, it's something that we have to become part of the solution by insisting that the option for transplantation is ours. And as uh, Dr. Scantlebury has pointed out in many times, it's the literacy issue. Very often, uh, the patients aren't given the option of transplant as much as other uh, people are. For example, they
Hmm.
may not be told that the likelihood of successful transplant, if you have a living related donor, is much better than if you had a deceased donor. And the option for going through and having navigation of the transplant process is something that we don't always go through, but it's so important because the success rate for living donation transplants are so much better than deceased donor transplantation. And we as
Hmm.
a group have not been eager to become living donors. And that's something that I think over the next few years, we really have to work even harder on to help us to take advantage of the fact that we need to have more living related donations so that we can have more successful transplants.
Hmm. Well, we had a roundtable on treatment options. Dr. Scanterbury was a part of that. And patients just are not aware that they have options. And that's always been a stickler with me. They're immediately put in an in center, and that's it. And that's where they either are going to die or just be on dialysis in a room with many other dialysis patients. So I think that's the first thing. You're going to go on dialysis, but there are other treatment options. And and there are so many new innovative things going on where there are many options and probably people working on many more. But thank you for that information. And I'm just so proud of both you and Dr. Scantlebury. And what I think about both of you is that, yes, you're African American, you're Black, or whatever you choose to call yourself, but you're making history. And it does
And
not
we
have
both
to be
have
called
Barbadian extraction.
true, but you're Americans, and that's the
Yeah.
bottom line. And of course, we need to acknowledge you as Black Americans, but it's not always necessary to define a person because what you're doing is history. It's phenomenal. And we are so proud of both of you that we can call you Americans and the fact that you are a part of Black history. And I think that's what Black history is all about, celebrating us, but at the same time, showing that no matter what color you are, here are these Black people right now that have done things with themselves and for history. And that does need to be acknowledged because we do many things. And but we just happen to be Black, and there's nothing that you can do to change that. So it's the truth. But I just think that I can't get over both of you. I really can't. And the fact even that the person that did my transplant is still working as well. And in fact, all of us are still working. So I'm overwhelmed. I really am. And I'm just so glad that both of you agreed to take the time to be a part of our roundtable. And I hope that we can continue to get people like you and Dr. Dr. Scantlebury at this same level because you both are top level. You really, really are. And the fact that you're all about education, this is what DPC Education Center is all about too. I believe it or not, I'll tell you, we had to move on. We got 5 minutes left. And I'd like to get a closing. Yeah, five
Yeah,
minutes.
one of the things I like to say that's
Hmm.
important as transplant surgeons, and one I remember when probably let's say 10 years ago, I was I remember thinking, if nothing else, I want to be able to inspire other Black female surgeons to enter into the field of transplantation. And I was writing my book Beyond Every Wall and highlighting those who were already there. My thought was I will not retire until we have at least 12 other Black female transplant surgeons. And to be able, and you think of 12, you think, oh wow, that's really
That's a
not a
lot.
whole lot. But it was really about so many of young physicians, surgeons, they don't see themselves in places where they feel they don't belong because that imposter syndrome, oh, there's no way I can do that. And so, as an example, many more are encouraged to say, well, okay, she did it. I can possibly do it. And so that encouragement, that ability to bring others along so that they can see that it's possible because we need more Black doctors, period. We need more Black surgeons because we know that there are better outcomes when your healthcare provider looks like you. And so I'm happy to say that each year there has been more and more. I think we might be up to about 20 now. So I'm ecstatic that we have been able to draw more Black females transplant surgeons. There always be a lot of Black men. Sorry, Dr. Callender, but the women needed that stimulation.
Uh, well, I'm so sorry, audience, but we cannot take questions now only because of time restraints. But if you have any medical questions that need to be answered, please send them to us, and I'll make sure that Dr. Scantlebury sees them and give her some time to answer because Dr. Scantlebury loves that. So please send in your questions. Okay, and I'm just going to get a few parting words. We got 3 minutes. I'll let you go, Dr. Skinnerberry, with 1 minute, and then Dr. Callender will have a minute just for a closing statement.
Well, thank you very much. I'm quite honored to be part of this roundtable and to by DPC, and thank you for the opportunity for me to share my experience. But my goal is to continue educating our society and our African American communities and aspire patients to understand that uh, when they are diagnosed with end-stage kidney disease, they need to equip themselves with all the information that they can, so that's if not them, maybe also their loved ones, so that when they're talking to the doctor, they can understand. They will know already what their choices are and be able to say, well, what about this? Because if it's not presented to you, you may assume that it's not an option. And I think that's so key that we continue to educate our communities about the need for organ donation and transplantation and to give of ourselves because we can't take it with us. And so we need to be able always thinking about helping others in every way that we can.
Thank you. Dr. Callender, you have
Yeah,
about a minute and a half.
I've been blessed. I think God has blessed me to live so many years and has blessed me to work with MOTEP, the National Minority Organ Tissue Transplant Education Program, to make a difference in transplantation, a difference that had to be made and a difference that was made. And so I thank you very much for the opportunity to get Dr. Scantlebury and myself together to
Right.
try to educate and empower even more people
Well,
to
we'll have to do some
get
more things
transplanted.
together, Dr. Callender. Seriously, I'll keep in touch with you because you have a lot of knowledge, and knowledge is power. So we look forward. And everybody, thank you so much for joining us. You can find us on Instagram, Facebook, and it'll show you how to get in touch with us because I'm sure you need a little more time for this presentation, and I could use about 3 more hours. So, as I said, get in touch with us. My name is Nancy Scott. I'm the Education Project Manager for the DPC Education Center, and we welcome all questions because even if you can't participate all the time, we do like to answer your medical questions because it's about your life. And we want you to live as long as possible and have a very happy, healthy life. Signing off now, everybody. Thank you so much. And please join our monthly roundtables. We have a support group. We have everything. So have a good day and thank you for joining.
Thank you so much.
Mm.
Have a good night.